Good morning, my dear students. Today's topic of discussion is emetics, drug therapy of vomiting, the antiemetic drugs, vertigo, and uh, the treatment in motion sickness, and also in uh, vomiting during pregnancy, especially in the first trimester. So, the vomiting, which is basically an unpleasant feeling, is a protective reflex which helps to rid the stomach of noxious material. Vomiting also occurs in physiological situations such as pregnancy, but often it is an indication of ill health and needs to be treated. The feeling of vomiting is called nausea, and the contraction of the accessory muscles when the patient is thinking that he or she will vomit, that is called retching. So here, before starting our topic, we have discussed three terms: the vomiting, which is also known as emesis; nausea, which is the feeling of vomiting; and retching. That means the muscle contraction, which will give you a feeling that you may vomit, or it is also happening during vomiting. So this vomiting reflex is basically a coordinated reflex controlled by a bilateral vomiting center in the dorsal portion of the lateral reticular formation in the medulla. So it is the medullary center, and it is guarded by blood-brain barrier. So the drug which is prescribed has to pass through that barrier to execute its action. The pharmacological interventions are sometimes required, or it is required most of the times, and it relies on inhibition of inputs or depression of the vomiting center. So the inputs are coming from various sources, and that will be discussed in the later slides. So here comes the slide which is showing the physiology of vomiting. The act of vomiting is accompanied by a complex series of movements, and is controlled by the vomiting center. It receives afferent impulses from higher center of brain. Here you see this is the emetic center of medulla, and this is the higher center of brain. So it is getting it from there. Chemoreceptor trigger zone. So CTZ is located here, so it's getting its impulse from here also. From the vestibular apparatus, that means it is related to your ear, so you will get it from the vestibular apparatus. You will also get it from the peripheral structures, including the GI tract and nucleus tractus solitarius. So here you see it is getting from the GI tracts, from the pharynx. It is also getting from, due to the local irritants, from the stomach. So this is from via GI tract, either directly via chemoreceptor trigger zone or via solitary tractus nucleus. And beside this, as I said, it will get it via cerebellum, from the inner ear via vestibular apparatus. And here you see the distribution of different receptors. So in the stomach and small intestine, you see there is serotonin receptor. In the chemoreceptor trigger zone, you see the distribution of dopamine 2, muscarinic, cannabinoid receptor, and serotonin receptors. In the medulla, you will see almost all these receptors. Solitary tractus nucleus, here you see all these receptors. With that, you will also see NK1, neurokinin 1 receptor, on which one drug act, which is known as apriptane, and the histamine receptor and the muscarinic receptors are also present in the cerebellum. And so in the inner ear, whenever the motion sickness or the motion problem is there, these muscarinic receptors and H1 receptors are going to be stimulated, and from where the impulse is going to the medullary center. So this is the basic physiology which is being demonstrated in this slide. So, just to summarize, a major sensory relay center in the afferent vomiting pathway is the CTZ, situated in the lateral border of the area prostema of medulla oblongata. Histologically, CTZ resembles the carotid body and is not a part of brain. Now, it is in the direct contact with the circulating blood, and it is not having the blood-brain barrier. So, it is outside the blood-brain barrier. And variety of drugs like morphine, apomorphine, alkylating agents like cisplatin and all these things, the digitalis stimulate the CTZ, whereas the phenothiazines and certain antihistaminics depress it. So, obviously, the phenothiazines and antihistaminics will act as a antiemetic drug. However, the chemoreceptor trigger zone, being a purely sensory relay center or station, is incapable of initiating vomiting in absence of vomiting center, whereas direct stimulating centers of the lateral latter, it will evokes the vomiting irrespective of CTZ. Now, the vomiting due to irritation or overt distension of the GI tract and delayed gastric emptying does not involve the CTZ, but is directly mediated by stimulation of the vomiting center via visceral vagal afferents. Similarly, it is likely that vomiting of the central origin due to there are some feelings like emotions, fear, anticipation, so memory. So, those things are even nauseous odors. So, these are responsible for involving CTZ. And beside this, on the other hand, the vomiting of vestibular origin is mediated via the pathway called vestibular nuclei. So, this is a completely different pathway, and it is related to cerebellum, CTZ and the vomiting center. There is a glossopharyngeal reflex which is arising from the pharynx. This is the pharynx, this is a glossopharyngeal reflex, and it's not a true vomiting, but it occurs as a result of failed normal esophageal function. Glossopharyngeal reflux is basically effortless and generally not associated with autonomic symptoms. Apart from serotonin, neither these neurotransmitters such as dopamine or neurokinin and histamine probably play an important role in the process of vomiting. So, 3 different neurokinins have been identified. So, what I said that other than serotonin, the neurotransmitters are dopamine and neurokinin, and there are 3 different neurokinins present: neurokinin A, neurokinin B, which are believed to act as neurotransmitters or neuromodulators. Substance P has been identified in the nucleus tractus solitarius, means here we have seen that presence of substance P, and it has been identified also in the area prostoma in the brainstem, and also in the these serotonin receptors are present in the small intestine in the enterochromaffin cells. So, it is excitatory in nature and can induce vomiting. So, vomiting is usually preceded by the feeling of nausea and increased secretion of saliva, bronchial fluid and sweat. The nucleus involved in the act of this coughing also take part in the act of vomiting, and the vagal, the vomiting and the cough centers have a close functional relationship, and the vomiting can also be induced voluntarily. Now, before going to antiemetics, let us know a little bit about the emetics, that means the centers which are responsible for producing vomiting. So, there are some centrally acting emetics like Hypomorphine Morphine. Morphine is a painkiller which causes vomiting by stimulating CTZ. The peripherally acting emetics like mustard, the antimony, the potassium tartrate, even the saline, simple saline water for gargling, like if you take it inside, it will form a sense of nausea and vomiting. Both peripherally and centrally acting emetics, that is ipecacuanha. So, if you know this much, it is good good for you related to emetics. You need not have to know more than this. And MSCs is sometimes used as life-saving methods if in case of drug poisoning, in case of some other things. But in some cases, we are not using vomiting as a life-saving method, like if somebody consumes sulfuric acid. So, in that case, the chance of damage in the esophagus is huge. We are not promoting vomiting. In case of kerosene poisoning, we are also not promoting this thing. And then comes the concept of again the antiemetics. So, the release of serotonin by enterochromaffin cells from the gut due to distension. So, this is being demonstrated here, and the intrinsic pathway afferent neurons via serotonin receptors and extrinsic primary afferent neurons via serotonin 5-HT3 IP receptors, the stimulation of 5-HT4 receptors, the 5-HT presynaptic terminals of IPN, and it enhances release of acetylcholine, and ultimately the calcitonin gene related peptides promoting reflex activity. So, basically it is the release of serotonin which is responsible for vomiting, and the mechanism has been explained by this pictorial presentation. So, ultimately the neurotransmitter which is responsible for the whole thing is acetylcholine by stimulation of 5-HT4 receptor. So, 5-HT3 is basically, if you give 5-HT3 blocker, it will stop vomiting. So as 5-HT4 agonist, that will also stop vomiting, but by a different means. It will increase the propagation of bowel, that means the movement of bowel, and therefore the bowel will be evacuated. And those drugs are etopride and cisapride, but those are not considered as a classical drugs in case of to stop vomiting. So, but these can be called prokinetic drugs. So, two groups of drugs are from this group. Considering the serotonin as a very important neurotransmitter related to vomiting. One is 5-HT3 antagonist like ondansetron, and the 5-HT4 agonist, which is classically not an antiemetic drug, but they are prokinetic drugs like etopride, cisapride, and this is all about the concept of serotonin, which has been a key factor causing vomiting when the impulses arises from the GI tract or intestine. So, what are the neurotransmitters which are playing a key role in this formation of the impulse of nausea and vomiting? Serotonin, dopamine, substance P, the endorphins, the histamine, and the acetylcholine. Beside this, there is another one which I have described, neurokinin A, B. So, these are the things which are playing a key role, and you have to either block any one of these, or you may have to give some kind of agonist to these drugs. It is depending on the role of the neurotransmitter. But these neurotransmitters playing their key role in vomiting or formation of nausea or these kind of conditions. So, which group of drug can be used as antiemetics? Serotonin antagonists, which we can understand, 5-HT3 antagonists like ondansetron. Dopamine antagonists, because I have shown dopamine as a neurotransmitter. D2 antagonists like metoclopramide and domperidone. Anticholinergics, the drugs, any one of the drugs like hyoscine, which is a very good drug in case of motion sickness, is going to be very useful. Usually a patch is placed over the mastoid process. And H1 antihistaminics, mostly the classical ones like chlorpheniramine, diphenhydramine, hydroxyzine. Those are the drugs which crosses blood-brain barrier, are going to be very effective because they are having an effect on the receptors present in the vestibular apparatus, the vestibular nucleus. So therefore, they are going to be very effective, and they are also having a little bit of anticholinergic effect. So basically, they are affecting the neurotransmitters like serotonin, dopamine, acetylcholine and histamine respectively. Beside this, as I said, there are few more neurotransmitters like substance P, neurokinins. So those are also playing some roles, and therefore their inhibitors are also playing a very significant role while stopping vomiting, especially in cancer chemotherapy induced vomiting. And there are some agonists which are required to stop vomiting, that those are related to cannabinoid receptor. So let us just go through the class, the examples, and where it is going to be most effective. If you can remember this, I think it is very easy for us to cover the whole chapter. So mostly we are using ondansetron, palazetron, this kind of drug. These are 5-HT3 receptor antagonists, serotonin antagonists. Hence, these are going to be effective when the nausea, vomiting, the reflex is arising from the GI tract or intestine, and also in case of cancer chemotherapy induced vomiting. Centrally acting dopamine receptor antagonists like metoclopramide, domperidone, they have a little bit of difference between the two, but domperidone crosses blood-brain barrier lesser than metoclopramide. Hence, the adverse drug reaction is more with metoclopramide. And obviously, they are also effective in cytotoxic drug induced emesis. Also, in case of something like gastritis related vomiting, it's going to be very effective. The histamine receptor antagonists, they are very effective in case of vestibular motion sickness, as well as doxylamine is basically a drug of choice in first trimester in pregnancy, where the morning sickness is the cause of vomiting. The muscarinic receptor antagonists, the hyoscine, where the patch is placed just behind the mastoid process, and it is effective in vomiting, which is related to motion sickness. Neurokinin receptor antagonist, this is apriptane. It has a initial reaction, the delayed reaction, and this one is very effective, where ondansetron is not effective as a not effective to stop cancer chemotherapy induced vomiting. You can always prescribe apriptane. Cannabinoid receptor agonist, this is the only agonist probably used here as an antiemetic, and the name is dronabinol and the nabilone. These two are the drugs which are basically used. The cytotoxic drug induced emesis can be controlled with this, but usually it is given as add-on drug, not as a primary choice drug. So there are different reasons, the clinical reasons for which we are seeing this kind of vomiting. It can be a manifestation, just a symptomatic manifestation of different disease. Maybe obstructive disorders, maybe some viral infections, the bacterial infections, maybe due to some inflammatory disease like hepatitis, maybe due to some sensory neuromotor, the function is altered. So in those cases where you see pseudo obstruction, in cardiopulmonary diseases, in myocardial infarction may be manifested with vomiting. The labyrinthine disease, the motion sickness, in case of these are all extra peritoneal. The previous ones are all intraperitoneal. And the postoperative vomiting, so these are all the extraperitoneal one. What are the medications? The drugs like used in cancer chemotherapy, the drugs which are antiarrhythmics, digoxin-like drugs, which is cardiac glycoside given in cardiac failure, the oral hypoglycemics may cause vomiting, and there may be some toxins and ethyl alcohol, which also may lead to this kind of problems. And there is one physiological condition that is called pregnancy, and this kind of vomiting is called morning sickness. Unless it is absolutely, the medication is required, better to avoid medication. Otherwise, you can give a combination of doxylamine and pyridoxine. Pyridoxine is a vitamin B6 and doxylamine is an antihistaminic drug. So these are the drugs which we used to prescribe in case of morning sickness in case of pregnancy. It's a physiological phenomenon. Again, I am repeating. Sometimes it is becoming hyperemesis gravidarum, and in those cases where it crosses the limit, patient may have to be uh, I mean admitted to the hospital, and in the symptomatic management like the normal saline and all those other things should be started as a symptomatic treatment of vomiting. Obviously, the drugs are also prescribed. So, in these conditions of morning sickness, definitely the doxylamine is not going to be that effective. The serotonin antagonists are ondansetrons. They are the potent antiemetics. Even though the 5-HT3 receptors are present in vomiting center and CTZ, the antiemetic action is restricted to emesis caused by vagal stimulation. It has a high phosphorus metabolism excreted via liver and kidney, and no dose reduction in renal insufficiency, but it needed in case of hepatic insufficiency. It can be given once, twice daily, orally or intravenously, and it's a very effective drug. Nowadays, it is almost replacing the drugs like metoclopramide and domperidone, which are first line drug in case of simple vomiting. So these are the dose of the drugs from the same group, where you see that in different doses it can be prescribed. The maximum dose of ondansetron is 32 mg per day. It is used in chemotherapy-induced nausea and vomiting, usually given 30 minutes before chemotherapy, and also in case of post-operative and post-radiation nausea and vomiting. The common adverse drug reactions is basically constipation. The severe constipation occurs with ondansetron. Sometimes the laxative or the purgative can be given to overcome that problem. All the drugs may prolong QT interval, and it may lead to cardiac arrhythmia, and the cardiac arrhythmia will be discussed probably at the end of the next week. Next comes the next neurotransmitter, dopamine, and again you require an antagonist, and it should be D2 antagonist, because D2 receptors are present at that particular zone of the CTZ as well as the dorsal center of the medulla, the vomiting center of medulla, and the drugs will antagonize D2 receptors in CTZ normally. The available drugs are metoclopramide and domperidone. Both drugs are prokinetic agents, as well as they are blocking the D2 receptors, so the dopamine action of dopamine is going to be stopped or prevented. And they are also having 5-HT4 agonistic activity, but they have a little bit of difference. Metoclopramide can be given oral, also via IV route, whereas domperidone is only given via oral route. Domperidone is probably the safest drug. It is not given via IV route because of the problem of cardiac arrhythmia. The metoclopramide crosses blood-brain barrier, but domperidone cannot. So, I shouldn't say cannot. Little bit of domperidone also crosses, but it is not that significant that it will cause some kind of adverse drug reactions. Now, you try to answer this question. Which one is a better antiemetic, metoclopramide or domperidone? Now, it is again depending. It's a relative question. If I'm talking about the adverse drug reactions and talking of the safety, then I will prefer obviously the domperidone, especially in case of children. But as it crosses the blood-brain barrier more, the metoclopramide, it will definitely prevent vomiting, which is due to the effect of the central effect of any drug, central effect of any kind of emetics, and that's going to cause a little bit of tricky situation in case of selection of the drug. But mostly we are preferring domperidone as it's a safe drug, both in case of children and in case of elderly people. But if injection is required, if the oral drugs are not sufficient, then you have to give injection metoclopramide, available in the very old brand name of Reglan. So that injection is given, and we are accepting this extrapyramidal side effect. Why it's happening? Because it is blocking the D2 receptors. And the problem is extrapyramidal side effects are such that the D2 receptors are blocked, and you will see that the dopamine level is present in the sufficient concentration, but the concentration is not, I mean, even if it is in the sufficient concentration, it cannot bind with its receptor. So the relative concentration will decrease. That is the problem, and that may lead to drug-induced Parkinsonism. So this is the source of drug-induced Parkinsonism, and this may also occur with antipsychotic drug or psychotropic medications like chlorpromazine and haloperidol, which are given in case of schizophrenia. So they will show similar kind of adverse drug reactions like metoclopramide. Domperidone is obviously a better and well tolerated drug. Apriptane, which is normally given in case of cancer chemotherapy induced vomiting, it's basically a not a first line drug, but when ondansetron is not effective, it is given as a second choice, and it's very effective non-peptide, and it's basically selective neurokinin type 1 receptor antagonist. It blocks substance P from binding to NK1 receptor, and the broader spectrum and the activity in delayed emesis in preclinical studies been already observed to augment the antiemetic activity of the serotonin receptor antagonist and dexamethasone. So that is the effect of apriptane as antiemetic drug. The drugs like phenothiazines and butyrophenones, which are basically, as I said, the phenothiazines are the chlorpromazine, the promethazanes. So these are all antihistaminics, and these phenothiazines are basically having basically antipsychotic drugs. So they are similar action as metoclopramide because they are D2 blocker, whereas promethazine is having antihistaminic property. So all these drugs can be given in case of vomiting. I mean, if the emesis is such that it cannot be controlled with any other drug, you may prescribe these drugs. Butyrophenone means the drug like haloperidol, droperidol, that can be prescribed. And ideally in case of postoperative nausea and vomiting, which cannot be controlled by ondansetron. So in those conditions, you can prescribe these drugs. Nowadays, the better drugs are available, so we are not prescribing these drugs. Now, H1 has antihistaminics. It has a multi-role. It can be given in case of simple vomiting or obviously in motion sickness, just like the anticholinergic drug hyoscine. All the drugs which are going to be effective in motion sickness because the receptors are H1 and M in the vestibular nucleus. So the meclizine, cyclizine, dimenhydrinate, diphenhydramine, the promethazine. As I said, promethazine is also an antihistaminic. So it is used in pregnancy. It's a safe drug, but nowadays we are prescribing doxylamine and pyridoxine combination as a guideline drug in case of pregnancy-induced morning sickness. And this promethazine is used for NASA for space motion sickness. The hyoscine is basically acting on again the muscarinic receptors present in the vestibular nucleus, and as it is given as the transdermal patch, it is very close to the place, and therefore the absorption is quicker, and you will get quick action, and it penetrates the blood-brain barrier, which is not seen with atropine. Atropine patch is also not available, and hyoscine is normally prescribed as anticholinergic drug in case of motion sickness induced vomiting. The drugs like cannabinoids, the cannabinoid receptor agonists like dronabinol, used as an adjuvant in chemotherapy induced vomiting, and so it's a psychoactive substance. Besides this, nabilone can also be used in this condition. Glucocorticoids can also be used as adjuvant drug in this condition, so as benzodiazepine. The anti-inflammatory effect, its direct central action on the solitary tractus nucleus, it's maintaining the normal physiological function of the organs and the systems, its action on the serotonin and on the neurokinin as 1 and neurokinin 2, it's reducing pain, the concomitant use of the opioids and the regulation of hypothalamic-pituitary adrenal axis is making it a very good antiemetic add-on drug. As a single drug, glucocorticoid never used as antiemetic drug, but it can be add-on with apriptane or ondansetron, especially in case of cancer chemotherapy-induced vomiting. One thing you must be able to understand and try to remember that beside this drug, the drug which I mentioned before, the doxylamine and pyridoxine combination is given as a drug of choice in morning sickness, which is basically a physiological phenomenon in pregnancy in the first trimester, till it is becoming hyperemesis gravidarum. In case of hyperemesis gravidarum, patient should be admitted to the hospital. But beside these two drugs, doxylamine and pyridoxine combination, rest of the drugs are not ideally recommended in pregnancy, but it is depending on the clinician and the situation. Patient may prescribe drugs like metoclopramide or some other thing if that person, the clinician thinks it's required for that particular patient. And injection metoclopramide is a drug of choice in case of morphine-induced vomiting. So, if morphine stimulates CTZ and causes vomiting, it will stimulate the CNS. It is basically crossing. It is not only crossing the blood-brain barrier. It is not only stimulating the CTZ. CTZ is not guarded by blood-brain barrier, but it also stimulates some other centers and it causes vomiting. And therefore, to prevent that, you require some drug which will prevent vomiting by crossing that blood-brain barrier. So, here you will get the advantage of metoclopramide over domperidone. Though there is a chance of drug-induced Parkinsonism and extrapyramidal side effect, but you should have this drug should have been given to a person who is suffering from morphine-induced vomiting because it crosses blood-brain barrier. So, in the question it is written that patient prescribed tablet ondansetron for prophylaxis of motion sickness. So, it is a very potent antiemetic drug. Cancer chemotherapy induced vomiting can be treated with this. Now, the question is, can we explain why this one is not showing any effect? The answer is the vestibular nucleus. If you see the third slide, and only two receptors are located. Muscarinic, it is non-specific. It does not mention whether it is M2 or M1 or M3, and the histaminic, that is H1 receptor. And ondansetron has no role on those receptors. It is a 5-HT3 receptor antagonist. That means it is a serotonin receptor antagonist. So, I would like to conclude my presentation with 2 points. Even though both atropine and scopolamine are antimuscarinic, why scopolamine is used in the treatment of motion sickness? So, the answer already I have given during the presentation. And the second one is, generally the transdermal patches, this is from general pharmacology, are applied over the arm or chest, but this one is applied behind the ear. Why? This is again a common sense question, is not related to medical profession. Now, think about the distance and you will be able to understand that quicker action will be, quicker action is going to be seen if you are prescribing it near the center, the vomiting center and chemoreceptor trigger zone. So, these are the two questions which should be, you should think and discuss among yourselves, and even if you get even a better answer, you can write it down. Thank you so much for your patient hearing.